Whether online, in person, or on the phone, the initial clinical interview is really about movement. It's metaphorical movement. It's metaphorical movement from the problem to the goal. In the beginning, after the intentional opening, most commonly, clients and patients want to talk about their problems. Psychiatrists refer to this as the chief complaint. It's the main reason people have come for some kind of therapeutic help. What's important is, from every perspective, that we understand the chief complaint and sometimes a little bit about the history of that chief complaint. Judy Beck, who does CBT, or cognitive behavioral therapy, emphasizes that one of the first tasks of the therapist is to do a problem list with the client, an interactive, collaborative problem list. Now, that problem list it might sound boring or rote, but really, gathering the problem list with the client is an unparalleled opportunity because there are several things that can happen. The first is, what better opportunity to show empathy when people are talking about the concerns and the problems that bring them to therapy? It's exactly when we want to show compassion and empathy for what the patient has been experiencing. In addition, it's an unparalleled opportunity to begin the collaborative process because the patient is the expert on his, her, or their own problem. That is who we need to get the information from. And yet, we're the expert on how to get from that problem to the goal. And so we have to do this collaboratively, and the problem list is one way that we can do it. We can begin that collaborative process, if only in that we will be actively trying to help the patient prioritize which problems are most important and which should be addressed first in the therapeutic situation. It's also an opportunity, and the brain is an amazing thing. Most people want to get a history of the problem. And anytime we do a history, we get a chance to notice the amazing way in which the brain works. So I might ask, when did this problem first start? And maybe it's panic. Maybe it's anxiety. Maybe it's a trauma. And in every case, as soon as I say, when did it start, the client or the patient's brain will start going back in time, kind of a zoop right back to the past, and you might get an original or early time when the problem first arose. Could be the problem is anger, and they go back in time. Now, that is a wonderful and a little bit frightening process, because it's wonderful because we can get some really rich information that will inform how we can help the patient address the problem in the here and now. But it's also a little frightening because if we go back in time, we can go back to traumatic, historical, emotional, difficult situation, and we need to be prepared to help the client or the patient through that process if we go back to the past. As we are getting information about the presenting problem, it's also essential for us to be thinking like a mirror, but also it's like being an active mirror. We want to use our reflections, our comments back to our patients or clients like a highlighter pen, where they might say something like, well, sometimes I've actually been able to make it through my panic. And so we want to make sure that we intentionally reflect that back, just like a highlighter pen in a whole book. We want to say back, so there have been times when you have successfully managed to get past your panic or your anxiety and recover from it in the moment. And so think intentionally about what it is that you want to reflect back to the patient or the client. Another important question to ask about the problem is, what is your best explanation? What's your best theory about why this problem is in your life? Again, you're going to get some fantastic answers. Sometimes the answers will be things like, it's because my son is possessed by Satan. Or you might get an answer, I'm just a bad person and I'm defective, or no one will ever love me, or the theories that people have about their own problems is something that we definitely want to access in the early part of the clinical interview, because those theories are what the client or the patient has been living with and thinking about, sometimes for years or decades. And to reveal those things to us and to let us begin some work on either using the theory in a positive way or helping them to move past the thought or the belief that they are unlovable is of great importance. In the end, the process can be kind of magical, but we also have to help our patients identify good goals or smart goals. The goals have to be specific, they have to be measurable, they have to be attainable, they have to be relevant, and they have to be time-bound. A lot of patients will come in for a first session with goals that are completely unrealistic. I remember a woman coming in and saying, my goal is to get my ex-husband to listen to me. Well, that's a wonderful wish, but the fact was that he hadn't listened to her for 10 years of marriage, and now they're co-parenting, and the likelihood that he would suddenly start listening to her was very, very small. And so we needed to massage that wish into an achievable, an attainable goal. People will also come in and say, I want to recover from my depression. And although that's a great long-term goal, we need to help them really kind of visually build some stairs from where they are now so that step by step they can move toward that longer-term goal and feel some small steps of progress along the way. So I really recommend that you focus on the movement in psychotherapy from problem to goal to help inspire hope in our clients that this process that we're engaging with them collaboratively will have a positive end result.